Welcome to A Clinical Breath, respiratory insights from industry leaders. A Clinical Breath provides the community with the latest respiratory developments, trends, and expertise, all aimed at improving patient outcomes. Today's episode is brought to you by Monaghan Medical Corporation. Monaghan means it matters. This podcast is for informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Opinions are those of the participants and do not necessarily reflect those of Monaghan Medical Corporation.
Hello, and welcome to A Clinical Breath, respiratory care insights from industry leaders. Joining us today is Dr. Michael Bowman. Dr. Bowman, welcome.
Thank you very much.
We're going to talk today about the underserved asthma population. And I guess we'll begin by asking you, why is that an important topic?
It's extremely important because the underserved make up a large proportion, at least in pediatrics particularly, of the people who have the worst control of their asthma. Mm-hmm. They wind up being in the hospital more, in the emergency room more. When kids are sick, they wind up not being in school, so schools lose money for attendance. It's estimated that asthma in the childhood population each year in the U.S. Causes something like 14 million days lost from school.
That doesn't count what the impact is on the parents' loss of employment and work when they have to stay home with a sick child.
That's also been quantitated, and it's about 14 million work days that are lost as well.
What do you mean when you say underserved? Some people think that that's going to be socioeconomically disadvantaged, whereas I think you're probably alluding to the fact that they're not being properly managed in a medical regimen.
It's both ways. Whenever they have a challenge getting to a caregiver, getting to the caregiver they need, that is a difficulty.
What about the stigma of asthma in terms of the parents kind of avoiding seeking help because of the diagnosis that might come?
That's a very important point, and the diagnosis of asthma needs to be made, and it needs to be made correctly. So it's a challenge to have folks who do have asthma recognize it, call it by its real name, and also have the folks who haven't yet been recognized actually get diagnosed. Typically, the ones that we see in our children's lung clinic, they've been called by the pediatrician reactive airway disease or post-viral wheezing or something like that. The pediatricians that I've dealt with and family medicine folks frequently are reluctant to actually say, your child has asthma. I know he's had wheezing or she's been sick with every cold for her whole 2 years of life, but they're reluctant to call it asthma. Also, folks who have a goal of their child ultimately getting into the military, having the diagnosis of asthma can preclude that.
So it's a stigma, so to speak. But at the same time, I think you can agree that asthma, once properly controlled, is really not that bad of a problem. If properly controlled, I think, is the key word.
That's very definitely the case. And one of the things that we've discovered in our inner city families a lot of times is they don't think they have any power over caring or changing the child's existence. They think the child got a bad deal, they have bad asthma, and they use albuterol, they go to the ER, and they expect to be hospitalized and get prednisone. And so they don't see any way of changing that. In our clinic, trying to figure out a way to explain why someone needs a medicine every day to control their asthma, even though the child is well, the only common thing that I could think of that made sense to many of our patients is face medicine. Moms know that you use acne medicine this week so that your face doesn't break out next week. And so I've taken to telling families, you take this controller medicine every day this week so her lungs won't break out next week.
So that's the problem, is that once I'm asymptomatic, it's like hypertension. You can cure it with medication, but to stop taking the medication, you're right back where you started.
Exactly, and it's a challenge for anybody, I think, regardless of where in the city and the suburbs and the rural areas they live, to take any medicine when there aren't symptoms. And so a lot of asthma, as you know, winds up being under the surface. They're able to do fine. They're not overtly wheezing. They're not in respiratory distress. So everything's fine. And there's an overlap very much between patients who have asthma symptoms and patients or kids who have colds. And so many of our parents think that, oh, it's just a series of colds. And that's one of the challenges for the primary care doctor, to convince them that this is a chronic illness. It's not just a series of colds, because everybody has 6 or 7 colds a year. Why is my child different?
Sure.
And so it takes a lot of convincing or educating folks to realize that this is a chronic illness. I use a comparison of icebergs, that a whole lot of the iceberg is under the surface, while a whole lot of asthma is under the surface
sure.
as well. And the family sees how many icebergs are in their existence for a year, and we want those to be small icebergs spaced way apart rather than all over the place.
One of the problems that respiratory therapists and asthma managers face, and physicians as well, especially with inner city where you really need to investigate the living conditions, and because poverty and socioeconomic disparity is a big part of it, how do you approach that when you're really kind of invading someone's personal space, but at the same time, it's critical to make the right diagnosis?
Exactly. And one of the things that we have to convince folks or illustrate to them is that every patient with asthma has their own triggers, and they have their own certain things that set off their lungs. And so trying to get them to be detectives to tell us, when does your daughter's lung go crazy? Is it just when they have colds? Is it when they try to play in sports? Is it when they go to grandma's house? Oh, by the way, grandma smokes. What's going on? And then it's recommended in many situations to do home visitation in terms of having an experienced layperson or nursing person, public health person, go to the home and look around and see, are there cockroaches? How much dust is there? Can you even find the medicines and that sort of thing? And many parents think, why am I going to let a stranger into my house? They're just going to tell me I'm a dirty housekeeper. And so getting people into a home to assist is a challenge. But if we can do that, there's the chance, especially if the visitor is of similar background to the parent, there can be peer-to-peer counseling in terms of, oh, my son had that problem too, and then we cleaned up the cockroaches, or when we moved out of a multi-unit dwelling, something like that. It can make a huge difference. I've had families where they expect every Thanksgiving they're going to be in the ER. They haven't had for 3 or 4 years a family Thanksgiving dinner because their child is always in the ER or in the hospital that week. One of the things we see that people need to prepare for is the back-to-school asthma flare that happens every fall in the U.S. and Canada. And many things cause it, but getting off those medicines during the summer is a problem. And so trying to get people to realize it hasn't gone away just because the child's doing well, able to play more during the summer and that sort of thing. There are still major issues. And the more someone is focused on being a single parent family, having 2 jobs, the issues and ideas from May get forgotten very often.
I've always prided myself on telling my students when I was in the educational world that asthma is an inflammatory disease.
Yes.
The bronchoconstriction spasm comes later.
Right.
Albuterol, overuse, misuse, how do we address that problem?
That often comes from getting the accurate assessment of how the child is doing, because one of the things that I think is important is that every child ought to be able to play hard every day. A lot of families get into the situation where they realize that their child can only play if they take albuterol, and so they're given albuterol before recess and before PE and that sort of thing. So they wind up hopefully only having rare actual symptoms, but because they can't play every day, I think of that as being that they have exercise-triggered symptoms every day, and that automatically qualifies them for controller medication,
Right.
and that if they do that, they can actually play without having the need for albuterol most of the time.
Then there's the issue of steroid phobia.
Yes.
I don't want my child to have stunted growth or
Right.
pituitary problems. And,
Right.
and how do you address that? Obviously, we know the difference between parenteral and oral, but
Right.
that's something that we know we have to sell it
Yes.
to the parents.
I wind up trying to explain to them that, number one, the medicines that we use for asthma, the inhaled steroids, are not the bodybuilding Arnold Schwarzenegger type bulk up steroids. Also, the fact that they're used to taking prednisone or its cousins after a flare or a hospitalization, and point out that you can take your controller medicine twice a day, every day for a whole year, and you get less steroid into the body than you get from one 5-day course of prednisone.
Sure, and that's always a short burst, too. I guess
Exactly.
you stress that. That's not for long.
Right. And so the idea is that they need to understand that steroids are an issue and we would like to avoid them. But one of the things we see a lot of times when kids come into our practice, when they're referred in, one of my questions is always, so how long do colds last? And how many courses of prednisone has he or she had over the last year? And very often they'll say, 6, 7, something like that. You're used to thinking that's okay, but it's not okay. And we can do a whole lot better with the treatment. And again, convincing you that the asthma is modifiable and you're the one who has the control of that.
One of the problems that we see in our area, and probably yours as well, is that we have over-the-counter bronchodilators. The Primatene Mist is the big example, and it's back on the market now, I understand.
Yes, unfortunately.
Well, why don't you tell us your thoughts about that? Why is it unfortunate? I think we all know the answer, but it's good to hear.
What it does is it masks the severity of something, that there may be a very brief benefit, but it doesn't seem to prevent someone from having their asthma flare continue and worsen. And so it makes the family think, oh, he's doing better. And then in the middle of the night, he can't breathe at all.
Sure.
And instead of being able to go into the emergency room semi-calmly, they wind up needing to call the paramedics, and it winds up being a problem. And so I think most of the asthma organizations fought fairly hard to get Primatene left on the non-market list.
What about access to medications? I know there are some concerns socioeconomically for parents that don't have insurance or they're underinsured. Do you see an awakening on the part of insurance companies to actually reimburse for controller medications with a proper regimen?
That is a major issue at this point. I think that every Medicaid plan and every insurance plan has their own formulary, and that's important. But those formularies are based on contracting pricing for the medicines that they put in there. We have the problem that while they will have 2 or 3 different inhaled steroid controllers, they're different. They may have different devices. They may be appropriate for a young child or not appropriate for a young child. They also very often make those changes with minimal notice to families and or to caregivers. And so what we tried to do in our practice was to get the Medicaid plans to agree that they would give us 3 months notice on when they were going to make a change, so that we would have a chance to tell the families, we need to change your medicine. We agree it'll be a fine medicine, but it's going to be different. Rather than have them come into the pharmacy and say, your medicine isn't covered anymore. We can get it for you for $300, but there's this other medicine. And very often those families leave the pharmacy without anything because they're suspicious. And every time they leave the pharmacy without their medicine, there's a finite chance they're not going to come back.
There's other issues with the underserved population, especially with the socioeconomically disadvantaged. Access to transportation, having parents being able to take their child to scheduled appointments. And these are all issues that go beyond the control of asthma, but are very important. We call them social determinants of health.
Yes.
And how does that impact this underserved population, in your opinion?
It's very important. One of the things that people sometimes fail to realize is that the emergency room is a horrible place to try to educate a family about asthma. And one of the reasons for that is that the parent's going to be worrying about getting the car back the next morning so that dad can go to work or whatever. Having a functional vehicle so that you can get to appointments, you can get to the pharmacy. I always tell families to find out where there is a 24-hour pharmacy. They may not get their regular medicines there, but they know where it is. So if they call and they need prednisone called in, they can actually get to it without having to go to the emergency room.
It's just amazing to me how many elements come into asthma control beyond just the disease itself.
Yes.
And the other one that comes into mind is the single parent.
Yes.
Who has multiple pulls on her with other children as
Yes,
well.
exactly.
And how do you find the time to carve out with this ongoing re-education?
There's an increasing use of school personnel for providing asthma care. And I had thought when I first started suggesting that a family have the school nurse give the controller medicine, they'd be insulted or taken aback. And virtually everyone has said, oh, that would be great. So that they know that it's going to be given. Mm-hmm. They may only see their child once a day, and they have problems supervising twice-a-day medicines.
Getting into the school nurse program, actually, and having the child carry their inhaler, is there still a problem with them carrying their medication and self-administering? And we're talking about the ideal case where
Right.
the child really knows how to use it, but yet there's still this stigma that you shouldn't be carrying that in your pocket.
Most school districts now do allow youngsters where they have the right paperwork filled out by the family and the provider or the prescriber to do self-carry. We frequently found that when a parent thought a 7-year-old was appropriate for that, we had concerns, and we might fairly often say, let's wait till next year. But kids now ride buses for a long time. It is fairly common for kids to get short of breath on the bus. And if their medication is just in the nurse's office, that can be a major problem.
Where do we get the resources? You as a physician have limited time.
Right.
Asthma educators tend to focus on the acute treatment. Where do we find the common ground to actually get that education where it needs to occur, which might be in the school, might be in the home?
Right. I think that education specifically for techniques and plans and this is what we want you to do, that's important, but they need to know and be retaught how to use their inhalers. And so we have recommended through our state asthma alliance to try to get a certified asthma educator in every pediatric practice that has more than 4 providers so that they could have one nurse staff member who is that educator for all the prescribers.
So you're approaching it in South Carolina as a public health issue. So
Yes.
it's a statewide initiative that allows various communities to implement what's best for the children.
Right, and our recommendation would be that each school district have asthma educators among their nursing administration so that there's a recognition of how important asthma is, because people forget that when kids are out of school, and many school nurses I've talked to never realized that the school lost money. In South Carolina, it was $29 a day per seat.
Yeah, it's average daily attendance, I think, is the formula they use to determine reimbursement.
And in many states, it's between $40 and $80 a day per child who's absent that the school district loses out on. So there is specific monetary incentive for the schools to have the personnel to get the asthma under the control so that the absenteeism decreases.
One of the problems with the children, of course, is peer pressure.
Yes.
And I noticed that some of these kids that are really well trained really are immune to that, but others tend to succumb. And how do you build up their psyche to the fact that they can really acknowledge the fact that they have asthma, but it's no big deal?
Right, and I think that is a disincentive for a lot of kids, and it's part of their maturing and understanding. And the school itself can help by doing asthma teaching for all of the kids in the school rather than just the kids with asthma, so that they understand that this is necessary. They don't want to see their friends in distress or coughing or missing for 3 days. That is very definitely a challenge for kids anywhere. They want to be like everybody else.
Sure, and they can be. I
Yes.
guess that's the question here. That's the take-home message with this right now. They can be a normal child growing up and enjoying all the fruits and benefits of a childhood education
Right,
and social interaction.
That's why in our clinic we always refer to our patients as children with asthma, never ever asthmatics, because we want them to be normal children who happen to have asthma and have that be the perception of the family and the child, grandmother, etc.
It really is a challenge. Dr. Bowman, thank you very much for your time.
Thank you.
And thank you for joining us.
You've been watching A Clinical Breath, respiratory insights from industry leaders, brought to you by the Monaghan Medical Corporation. Monaghan means it matters. Thank you for watching, and tune in again for more respiratory-related topics.